afternoon, ladies and gentlemen. Once again, I welcome everyone back to yet another session dealing with smart and connected healthcare-enabled devices by Internet of Things. So we have had sessions in which we have spoken of such issues already, and it came out quite clearly that handling the volumes of data, data privacy, data security, and those are the real challenges. So in this session also, I would request that if in case there is more light that can be thrown, our understanding is that blockchain can handle many of the privacy issues. But yes, of course, practitioners would know more. So if there are more views on this particular issue, they'll be welcome. So I'll just introduce the session chair, General Narayanan, and Admiral Chawla. So General Narayanan, he retired as the head of, I'm so sorry. He retired as a former DCIDS medical and is presently head of the Department Neurology, Manipal Hospital at Delhi. And he's a postgraduate in neurology, rich experience in leading clinical services, teaching, and research in neurology for the last 20 years at the largest tertiary care centers of the armed forces. As a Major General, he was Deputy Commandant and Dean Academics at Army Hospital Research and Referral, and Senior Consultant in Medicine. He has been a teacher, a research guide, and examiner for MD Medicine and DMB Neurology students. And he has contributed richly to the implementation of telemedicine to soldiers in remote combat posts of the armed forces, and collaborated with industry leaders in deployment of e-health and artificial intelligence in the armed forces medical services. And he has been awarded Vishesh Seva Medal thrice through his brilliant career. So indeed, we couldn't have had a better person chairing the session. I would also take this opportunity to introduce to you the keynote speaker, Vice Admiral Chawla, Vishesh Seva Medal. He is the Director General of Medical Services, Navy at the moment, and he is a renowned teacher, and in addition to being a professor of pathology, is also an MD examiner at Maharashtra University of Health Sciences. And he has held the appointments of Director General Hospital Services, Armed Forces. He has also headed the Command Medical, he has been the Command Medical Officer of the Headquarters Western Naval Command and Executive Officer of INSH Ashwini. And he has had the unique distinction of commanding 2 out of the 3 largest Indian naval hospitals, that is INSH Ashwini and INHS Cmde. And he has also been the Fleet Medical Officer of the Eastern Fleet. So indeed, a very varied and rich experience in the Indian Navy. So he brings a very unique perspective. So with these words of introduction, I hand over the session to the chair now. Thank you.
Thank you for those kind words, sir, and please accept my profuse gratitude for inviting me for this very important session on the use of Internet of Things for smart healthcare. I'm always grateful to General Arora for taking such important topics and bringing to a very wide audience. We're all indeed deeply into the clutches of the brave new world that Aldous Huxley envisioned almost a century ago. While I was always interested in the interface between medicine and technology since the early days of the internet, I was thrilled when Sergeant Vice Admiral A. Pawar, the then DGMS Navy, asked me to deliver a keynote address on artificial intelligence at the Bombay Medical Congress a few years back. An invitation to give a presentation on digital health at MedLab Dubai last year rekindled my passion. Experts from almost 150 countries gathered in this conference to exchange views on the changing face of healthcare delivery. As we all know, Internet of Things, big data, cloud computing, and artificial intelligence have revolutionized healthcare, making it more efficient, more convenient, and more personalized. Beyond smart watches and smart glasses, we now have body wear and other kinds of accessories that can be deployed to monitor the health of an individual. Embedded, implantable, or ingestible sensors can monitor everything from a baby's heartbeat to the body metabolism in the elderly in a home care institution. These can not only monitor but can also be programmed to administer medications and therapeutically intervene in other ways, such as administer shocks to a patient who's had cardiac arrest. This data is not only useful to the patient but can be pulled together to study and predict healthcare trends across cultures and countries. The possibilities actually are truly limitless, and it is confined only by our imagination. I will, however, play the devil's advocate and touch upon some vulnerabilities of this approach. Some of these issues have also been touched upon in some of the previous session. I heard General Aftab Alam talking about it. But these are very important issues as we take this whole agenda of Internet of Things and smart healthcare forward. Firstly, the connectivity issues in the digital divide. Worldwide, the UN estimates that almost 3.8 billion out of a total population of around 7 billion are offline. So this will definitely increase the divide between the haves and the have-nots, and particularly in the field of healthcare. Secondly, what about privacy issues and biosurveillance risk? We had this incidents in South Korea where they were so strict on their COVID monitoring that each person who was COVID positive was monitored almost continuously on a 24/7 basis by surveillance of their smartphones. So this actually leads to a lot of privacy issues, as we all understand. And secondly, ownership of the healthcare data is also very important, and this evidently leads to a loss of civil liberties. And because we are all handing over our data to private and government institutions. In most cases, governments and big data and technology companies are storing citizens' medical information, leaving many concerned with how this data is going to be used and who has access to it. This is a very important issue. And we all know that more sophistication also has then there is more potential misuse and abuse as well. All technologies that are being used for the good of mankind ultimately falls into the hands of people with less noble intentions. Denial of service attacks. We have all heard about the colonial pipeline attack in the eastern coast of the US, which brought the US to its knees, can also affect healthcare systems and affects patient safety. While most the common defense for denial of service attacks is redundancy, in a healthcare environment, it may be difficult to provide this redundancy because many of these monitoring devices are deeply embedded into critical life care systems. We all know about the WannaCry ransomware attack in 2017 and the sorry state that the NHS was in for several months after that. And I also had this very scary thought of what about a swarm of drones taking out people of a specific category, in a room who have been genetically and racially profiled with all these monitoring systems that we have while sparing others. So one category of people are wiped off and the other is preserved. And there are so many issues that we need to tackle, and I'm sure the extremely eminent faculty that we have will throw more light on these aspects with a humongous amount of wealth of knowledge, experience, and talent that I've been singularly blessed with. I now invite Surgeon Vice Admiral Naveen Chawla, who's already been introduced, to deliver his keynote address.
Good afternoon, Chairperson, sir. General Narayanan, we vividly remember the excellent talk you gave on artificial intelligence at the Bombay Medical Congress a few years ago. And at the very outset, let me thank the Center for Joint Warfare Studies, especially General Srivastav, General Ravi Arora, and the entire organizing committee for giving me this opportunity to be with all of you this afternoon and speak at this very prestigious forum. The topic, as has already been mentioned, is smart and connected healthcare enabled by IoT. Now, So said the late Padma Vibhushan, Dr. Vikram Sarabhai, who unfortunately passed away in the year 1970, that the development of the nation is intimately linked with the understanding and application of science and technology by its people. Now, that was several decades ago, but you know how true his vision, and he was the father of the Indian space technology, and how true was this vision of his several years ago. Now, what exactly is the network? What exactly is IoT? It is Internet of Things, and this is a network of interconnected devices linked through the internet that can send, receive, monitor data without requiring any human interface. Now, basically, there are 5 larger components of this, and the components are basically the device, the gateway, the cloud, the analyzer, and the user interface for understanding how this system works. So at one end, you have the IoT devices that catch and transmit data. You have the gateway, which is a physical device or software that ensures a common platform to process the data. As the data generated is vast, it needs a place to be stored. And here comes the role of the cloud, from which the search engines derive data in real time. The last component is the user interface, which allows visual interpretation of the information. The term IoT, Internet of Things, was coined in the year 1999 by a British pioneer, Mr. Kevin Ashton. IoT can be used in almost any field imaginable. For example, let's take logistics. You have smart warehouses which optimize the demand, the transport, and the delivery of products. In transportation, IoT is used to guide traffic control, the commercial transport services. In the energy sector, you can optimize energy use in residences. Now, with ever increasing health demands, coupled with restraints in workforce and limited resources, the use of IoT has gained a place in healthcare also. IOMT is the Internet of Medical Things. This is an extension of Internet through medical devices with capabilities of identification, sensing, and data exchange. Common examples, as we all know, are smartwatches, the e-stethoscope, and these applications create an individualized health footprint. Now, if you think that internet has changed your life, let me just say that please think again. This is just the beginning of another new world, and things are going to change very much more in the future ahead of us. Broadly, there are 2 sectors in which IOMT is used in healthcare, and these are classified as either services or applications. Services are a system for supplying routine healthcare needs such as health parameter, monitoring through wearable devices, maintenance of e-health records, drug dispensing via smart pillboxes, ambulance services, or utilities such as outreach community activities and ambient assisted living for impaired seniors at home. Application is the use of IOMT algorithms to provide e-healthcare. This can be a single-use condition or a clustered-use condition. In the single-use condition, IOMT applications are used to monitor health parameters. An example is the Swasthya Slate or the Android-based health tablet used by sub-centers by auxiliary nurses for monitoring of blood pressure and blood glucose levels in the non-communicable disease prevention program. The other one, that is the clustered application, are used to manage large systems like wheelchair management in smart hospital, rehabilitation care in elderly homes, medical management of patients, especially when human contact with patients are fraught with danger. An example is the use of sensor technology and analytics to monitor Ebola patients developed by the WHO during the Ebola outbreak in Africa. Smart hospitals, where the patient monitors are remotely monitored at nursing stations, ambulance equipped with real-time feeds to navigate through the busy traffic of a city. IoT has enabled such functions as on date. The smart pill boxes ensures that the right dose of medicine is dispensed at the right time. Its benefits in elderly patients and patients with dementia are indeed enormous. The application of IoT can be at two levels, which is either at the individual level or at the community level. Let's take the first, that is the individual level. The electronic health record of the individual hosted on cloud is analyzed to detect derangement in health parameters. Health application on mobile and monitoring of chronically ill patients at home are some of the examples. And at the community level, the aggregate data is harnessed for research and measures for outbreak control investigation. The advantages of IoT are that it saves time to healthcare professionals and enables them to consult more patients. It increases access to basic healthcare facilities at the remote areas. Real-time monitoring of patients improves proactive prevention. A research by the Global System for Mobile Communication showed that around 70% users had expressed peace of mind after using the IoT. A study done to estimate the cost savings by use of IoT was done by Accenture in the year 2017, and that showed a significant cost savings both by the providers as well as the payers, and apart from this, the comfort and the good feel-good factor which came along with it. Realizing the importance of digitalization in healthcare, the WHO has organized the first guidelines on digital health interventions, which provides access to open web health applications. The Digital Information Security in Healthcare Act, or DISHA, one of the first steps in Digital India. NEHA, or the National E-Health Authority, is the nodal authority for development of integrated health information system. In the year 2019, the National Digital Health Mission, with the motto, Think Big, Start Small, Scale Fast, was launched. And that seems to be the way ahead for the nation. There are several factors which form a wall and prevent this progression of IoT technology. As General Narayanan had brought out, that there are privacy issues. Then, in addition, there's a lack of skilled, readily available IT workforce, which is going to take on this task. Data security, as brought out by the chairperson. Then there are softwares, since multiple softwares of different devices are kind of integrated with each other, they need good compatibility. Economy, budgeting, costing are of course very significant factors in this world, which is getting increasingly expensive by the day. And still, what is a little unclear is this business model of the IoT and how forward can we all take it. The way ahead, to improve the odds of avoiding a security breach, there are two very important things which we must know. And one, that this data should be very well encrypted. And second, that the hardware which is used and the software which is used should also be very secure with no embedded malicious parts or malicious viruses. Interoperability, as I had mentioned, means the ability of two systems to communicate and share services with each other. IOMT data is generated in heterogeneous formats and thus hinders processing of aggregated data. So hence, standardization of the various devices, the validation of the devices forms a very important part in the scalability of IOMT. Very importantly, as already mentioned by the chairperson, is the ethical part of this. Who is exactly the owner of this data and who is responsible for this vast quantity of patient data, which should not be misused with an illegal and unethical intent, and there is a need for proper laws governing standards to ensure safety of this entire IOMT network and devices which are being used on it. To sum up, I would say that IOMT will only be limited by human creativity and resources. And whatever you may imagine, it seems that the future will have it and hold it for the generations to come. Significant challenges, of course, remain in the economic part, the security and the ethics, as I have already mentioned. Hence, it is important that you embrace technology with checks and balances in place within the frameworks of guidelines, policies, legal issues, and that seems to be the way forward. In the year 2003, there were barely 500 million IoT devices, but this is a future of exponential growth. And just like our mobile phones and mobile technology, which came in a few decades back with minimal usage, today it is accessible to many, many individuals across the globe. So IoT and IOMT is definitely going to play a big role in the times ahead. Thank you very much. Once again, I thank the chairperson. I thank the organizing committee for allowing me here to be with you on this wonderful afternoon. Thank you very much.
Thank you ever so much, Naveen, for such a simple and elegant presentation, running us through the important aspects of Internet of Medical Things and how it will change the face of healthcare in the times to come. We will take questions at the end of the session. I will now invite Air Commodore Shankar, who is now Air Commodore AFMS Planning and Training in the office of the DGAFMS. And to the medical fraternity, Air Commodore Shankar needs no introduction. He is one of the true gems that the Armed Forces Medical Services produce, and I think his credentials are very impressive and makes us all of us very proud. He's a gold medalist from Pune University and a former head of department in the Internal Medicine Department of AFMC Pune. His research areas are autoimmune diseases, proteomics, mathematical modeling, and artificial intelligence, and he's published several landmarks papers on these subjects as well. He has also published several numerous professional papers in his own subject of interest and has received 23 academic and research awards, including the prestigious ICMR MN Sen Oration Award in 2018 and the General Amir Chand Award in 2021 by the National Academy of Medical Sciences. You do us really proud, Shankar, and we're looking forward to listening to your presentation.
Is it visible, sir?
Not so far. Yeah, now it is.
Okay, great. Thank you very much for such kind words, sir. Firstly, I would like to thank the organizers and Center for Joint Warfare Studies for having given me this opportunity. And I'm going to take a slightly different approach in my presentation. I have been listening to the program from morning, and already 3 speakers, General Londe sir, General Alam sir, and now Admiral Chawla sir, have actually spoken a lot about Internet of Things, remote device monitoring, telehealth. So if I take you through the same thing, it will kind of become repetitive. So what I'm going to do is I'm going to give you a flavor of IoT and artificial intelligence the way I have looked at it because of the small experience of certain research projects that I have done. And I look at these as a flashlight, which you can throw at a problem and come up with novel solutions. So hopefully at the end of this 15 minutes of presentation, maybe the people who are listening to it may also be, encouraged to take this torchlight in their hand and throw it. But before that, I'll tell you two small stories. So 25th September 2021, Mohammed Fitri at Singapore decides to go on a joyride in his motorcycle. He chooses one of the lesser traveled path. Unfortunately for him, a van hits him, he's thrown off his motorcycle, sustains a head injury, and is lying unconscious. The van runs away. Luckily for him, he's wearing an Apple Watch, and this watch has got something known as a fall algorithm. The watch fall algorithm, it's supposed to send a trigger if it detects a difference in height. Throughout the journey, the watch was traveling at about 3 feet above the ground where the motorcycle handle is, and now the watch finds that it is at the ground. So it sends an alarm to Mohammed Fitri's cell phone, but Fitri is unconscious and obviously does not respond. The watch, after a certain duration of interval, searches the most frequently contacted person, which happens to be his girlfriend, Sayang. So it immediately sends a message, hard fall, and it sends a location where Fitri is there. The girlfriend reaches the place in an ambulance, and 3 weeks later, that's Mohammed Fitri on the path of recovery. Closer home, Mr. Rawat, he's from Nainital and he's a patient of bronchial asthma and he uses an inhaler regularly. But he doesn't use an inhaler like the way you and I do. He has got a smart inhaler. This inhaler communicates with his cell phone. Mr. Rawat has decided to come to New Delhi. So he gets into the car in the morning, switches on the Google map and sees the route and starts driving. The inhaler senses that his cell phone is moving away from itself and it's also able to see the Google map. So by sensing it, it immediately sends an alarm to Mr. Rawat. More interestingly, it has figured out that he is traveling to Delhi, and Delhi is possibly one of the most polluted areas in the country. So by its algorithm, it knows that his asthma is likely to become worse. So not only does it ask him to turn back, come and collect the inhaler from home, but it also gives the list of the various doctors in Delhi he can contact in case his asthma should become worse. Ladies and gentlemen, welcome to the world of Internet of Things. IoT is all the people, like they have mentioned already. It is a list of all the various things which are connected to each other and to the internet so that it is able to come up with various decisions which would land up helping you in coming to various solutions. And see you in 15 minutes, please. Now, if you land up seeing in the last 10 years, there was, if you see all the devices which were connected to the internet, almost 90% of them were either mobile phones or PCs or laptops. Whereas today, if you see, more than 50% of the 35 billion items which are connected to internet are things, that is neither laptops nor PCs nor tablets. How does it work? And it's already been discussed in detail by my predecessors, but at the heart of an IoT lies artificial intelligence, and I would devote the next 2-3 slides in taking you through the idea of artificial intelligence. What exactly is intelligence? If you ask, it is a general mental capability that all of us possess, by which we are able to reason, plan, think in an abstract way, comprehend complex ideas, and learn from experience. If a machine is able to do that, we call it as intelligent. That is, it is able to think like humans. I just want you to remember two things. Unlike a conventional program, an AI program can learn from experience and keep becoming better over a period of time. The second point is, artificial intelligence does not need IoT, but IoT cannot function without artificial intelligence. Some of us are likely to be very well aware of it, but some of us might not know that we are surrounded by AI and IoT anywhere that we look. Every time you go home and speak to Alexa or Siri, you are actually using AI to listen to your favorite song. When you visit the Amazon and it gives you various choices the next time you visit of the books, Amazon has used an AI algorithm. Every time you open your Gmail, more than half the mails are sent to the spam using a AI algorithm. Every time you took a flight, the choice of the runway to land and the taxiing track and the exact place where you would go in the bay is determined by AI and IoT algorithm. This is no more do humans interfere in these kind of decisions. AI is actually of three types: narrow, general, and super intelligence. And artificial narrow intelligence excels in one dimension. If I have to show it diagrammatically, this is how it would look like. Artificial general intelligence is something like a human being. It is a jack of all trades. And an artificial super intelligence will be master of all trades. As of today, we only have ANI. If you look at who is the best chess player in the world, from 1996, when the Deep Blue defeated Garry Kasparov, it has been a computer all along. Already has been mentioned by Admiral Chawla, sir, that your Amazon logistics is totally controlled by artificial intelligence and IoT. We are all aware of the self-driving cars and long-haul trucks, which are driverless. We have robots today, which can construct an entire house in just 2 days. We have pizza delivery drones, which is totally controlled by AI. And we even have applications which can make these pictures like Picasso. Now, here is an important point. The chess playing AI algorithm can do none of the other 5. Ladies and gentlemen, I am capable of doing all the 6, albeit in a terrible way, but so is each one of you. That is the real fundamental difference between an artificial narrow intelligence and an artificial general intelligence. Where exactly can we use it in healthcare? And it is in this section that I shall be sharing some of the experiences which we have gained. It can mainly be used in patient care, research, and administration and logistics. When I was at AFMC, I was responsible for handling the HIV at the Civil ART Center, and we used to get about 300 patients every day. Now, when you're having such a huge crowd, it is, even though one is able to see the OPD within 7 to 8 hours, but these HIV patients would land up having hundreds of queries. And many of these queries were extremely personal in nature, related to certain sexual habits, etc. And it is very difficult to sit one-to-one solving these queries. So here is a problem which we decided we are going to solve using AI. So what did we do? We have got a funded project for it, and we are halfway through the project. The first thing we did was we realized that we identified about 100 common questions which are there in the minds of HIV patient. And among a group of experts, we started developing 1 to 2 minute videos which of answers to these questions. Thereafter, we are at step 1 converting these 100 videos into 8 Indian languages: Tamil, Malayalam, Telugu, Hindi, Bengali, Punjabi, etc. And in phase 2, we shall increase it to other 25 odd languages. Now imagine there is a person who sits in the privacy of home. This is just a representative picture, and asks a question in own language, let's say Marathi or Bengali. Now, almost every Indian has got a smartphone, and so it's not very difficult to download a free app and click on the button and just ask the question. By using the principles of natural language processing, or NLP as it is called, the AI algorithm would choose the most appropriate video which is likely to answer this question. And once the person listens to this 2-minute video by an expert, that expert could be me or another of the doctors in AFMC, he would either be satisfied with the answer or not satisfied. If the person is satisfied, we stop it then and there until he goes to the next question. If he's not satisfied, a second choice, and thereafter a third choice again is given. if the person is not satisfied after 3 different videos, it would mean that we possibly have not made a video to answer this question. It gets into our database and we create a new video. And this way, this algorithm becomes better and better, possibly with 120 to 150 videos. This is actually a variation of chatbot. We went through a few of the chatbots and found the real weakness of the chatbot is you try it out yourself. After the second or third question, it starts giving really meaningless answers. So it has to be a specialist who gives really good answers. If you look at the field of medicine, there are 2 types of specialties. Those which are very patterned and those which do not follow any pattern. Radiology, dermatology, histopathology are the ones which are very strong pattern specialties. Most others do not have any strong patterns. Those of us who keep coming across various research things, AI, fundamentally most of the people go after pattern recognition. So you will come across hundreds of papers on chest x-rays, CT scans, MRIs, retinas, skin lesions, etc., because essentially you are distinguishing between one type of pattern versus an abnormal type of pattern. I am an immunologist and I deal with an exotic group of diseases called autoimmune diseases, and prototype of which is something called lupus. We have a very interesting and important test known as anti-nuclear antibodies, which we do by using something called immunofluorescence. There are actually 30 to 40 patterns, but 6 of these patterns dominate. Right now, we have got a funded project where we are looking at about 13,000 such pictures, out of which we will be using half of it as a training algorithm, and the other half later we'll be doing a validation algorithm. Once we have it, tomorrow, if you are a single specialist in Meerut or someplace, you just land up getting these pictures, put it under a microscope, and the AI algorithm will tell you what type of illness this person might have and what exactly do these pictures represent. So it's only we can do pattern speciality. No. Look, let's look this in ICU. For those of you not able to see the patient, can you see this? This gentleman here is this patient. This is how an ICU looks, where a patient is surrounded by some 20-30 machines. Now, typically in an ICU, the nurse or the doctor sees the patient every 15 to 30 minutes. So if you're going to have 20 pieces of equipment connected, which is capturing various data, so which would mean the real-time data is somewhere getting lost because you are only able to see it every 15 to 30 to 60 minutes. So we are looking at certain projects where we can look at the big data in real time and possibly be able to predict sepsis earlier, or we can, even if a person has got sepsis, we may say whether this person's mortality is likely to be earlier or no. In fact, this is a gold mine. Some of the best data in the is with the armed forces. Right from 1950s, we have got medical records of everybody. But though it is a gold mine itself, it's actually rather poorly organized. Reason? It is kept in multiple formats. You've got both paper and computer format. It has got a different types of, even in the paper, you collect the data as an AME or a PME or an opinion or a board proceeding. And it is also kept over 40 to 50 or maybe even more locations. Now, if we have a IoT based or an AI based algorithm by which we are able to connect all these things, we are actually looking at some amazing publications from the armed forces. Ladies and gentlemen, Paul Krugman got the Nobel Prize in Economics in 2008 and said, productivity isn't everything, but in the long run, it is almost everything. I'm not aware of many things which can fight for the position of almost everything. What is occurring to productivity in the healthcare sector? As healthcare becomes increasingly complex, as Indians and people all over the world, they live more and more, the OPD has started becoming bigger and bigger. More and more, the numbers have become more. There's a perpetual staff shortage. The people have become more litigious, so there is more and more contracts and more paperwork. Add to that the pressure of time, the pressure of electronic health records. And what has actually occurred is an interesting reality. This is another project which we are now exploring. The nursing across the world, including India, is in deep crisis. I did a small homework. A nurse spends about 70% of her time filling between 45 to 65 registers oblique databases on a daily basis. If this is not only true in the armed forces, this is true for every hospital across the country. So what is occurring eventually is that only 30% of the time is being spent by the nurse in true patient care, whereas there is a tremendous pressure to fill all these forms which keep cropping up. This leaves the nurses and the patients deeply dissatisfied. So we have come up with an interesting idea for which we'll be asking for funding, where we plan to use conversational artificial intelligence and IoT. Now this is how it will work. Now a nurse, she carries a tab or this thing, and she also keeps a small checklist. And instead of a 20-minute round, she actually takes a 2 to 3 hour round. She speaks for 12 to 15 minutes with each of the patient, but she also has a small checklist of the type of questions additionally to ask. As she keeps speaking, the voice keeps getting recorded and the key data points keep getting auto-filled in the relevant databases. The patient is extremely satisfied that this nurse has spent 12 minutes with me. By the time the nurse has finished her time and reached the computer station, 70 to 80% of the data points has already been filled by the conversational AI. The rest she does manually. Doctors are no better. If you see the data from USA, the number one cause of physician burnout is the pressure to fill electronic health records. There's an increasingly demand from administrators and regulatory bodies to fill up form after form. Ladies and gentlemen, doctors in USA and UK see 12 to 15 patients a day. The day I have an OPD less than 40, I jump with joy. 60 to 80 is the norm. Now, obviously, there is no study like this one, but the pressure is increasing on all of our doctors of filling up these forms. This is not going to go away anywhere. Again, conversational AI can come for a rescue, and eventually I think it would land up permitting us to make an eye contact with the patient and possibly touch and talk to the patient. You can imagine I'm speaking to a patient, looking that side and typing out. It is such bad manners, but that's how most doctors are seeing OPDs today, courtesy the administrative pressures. We are passed through we are in the middle of the fourth industrial revolution. The 60s and 70s heralded the third one with the advent of computers and electronics. And today, with the coming in of artificial intelligence, big data, IoT, and robotics, we are in the middle of the fourth industrial revolution. Some of you may be wondering, all this is fine, but where can I start? Where can I get a simple stuff where I can spend a few hours and get a hang of all this stuff? I would recommend go to this website. This is Sanna Marin, the 36-year-old Prime Minister of Finland. As a Christmas gift of 2019, the Finland government spent a couple of $1 million and developed this beautiful course, very simple course. I have done it as a beginner's AI, and it is really, really simple, and anyone can understand the principles of AI. This can be a good starting point. And if there's a book which you would like to read, I would suggest read all the books by Eric Topol, especially Deep Medicine, which actually focuses on how we can make healthcare human again. Ladies and gentlemen, the future is already here. The way we have been practicing medicine in the last 15-20 years is not how it is going to be practiced. We are going to be inundated with data. We are going to have patients coming who are extremely well educated. We require a very, very different approach. And I think it is the AI which would be able to help us, throw light on the complexities of healthcare and permit us to come up with innovative solutions. Believe me, the AI and IoT are far closer than what we think they are. Thank you very much.
Thank you ever so much, Kumdo Shankar. I think that again was a brilliant presentation, as is your style. So we have covered a lot of topics from morning to now, and as you said, a lot of ground has been covered. And I would like to say that the Armed Forces Medical Services is the organization which is singularly most poised to exploit this potential to the maximum advantage. But unfortunately, so far, if I may say so, we have not reached that potential. Where we lack possibly is we are not bold enough in collaborating with the industry. Because while we are talking about all these technologies, we are moving away from our core competence, and we must definitely actively collaborate with the industry and the experts in this field so that we can work together We have a fantastic organization which is spread out in so many different parts of the countries and which is already providing excellent medical care. But to take it to the next step, I think we'd have to be bold and collaborate with industry. We did have one such venture. When I was DCIDS Medical, I put together an event along with Accenture at Army Hospital R&R on artificial intelligence. On the other end of the spectrum, the DCIDS Medical got a huge gamut. I did have a conference on Ayush as well. So we have to take all sections of society together and move forward. And I think it was a fantastic session. I would definitely invite participation from the audience. I'm sure there are, and we have such eminent speakers here. We'd like to exchange our views a little more in depth, on the subject. One is, Shankar, the one, and you are actually in an appointment which can actually be pivotal in making this change happen. In the office of the DGAFMS. We have kind of, I think, held back a little bit, including when we are talking about you brought out so well that all our medical records, invaluable medical records we gathered, but we gathered them in such a way that actually they cannot be collated and put to any use as of now. So how do we make this big leap? Like even in my 3 years of corporate practice, I've seen that they have moved miles ahead as far as going to a paperless world in the delivery of healthcare. We have a lot of ground to cover, but I firmly believe that we are the ones who can take it to the next step, leapfrog, go much beyond what the others are, if we have the will. And we have the will to collaborate actually, because in-house expertise in these fields is fairly limited. You may have a few persons with some expertise in the IT department, but that is not how it works. Like we are talking about big data here, and we have to talk about the industry leaders who can take it, and then we have to collaborate it with them.
So there are multiple components to your question. Actually, see, the thing is that when it comes to, for example, your electronic medical records and EHRs, to a vast extent, for many of the modules, Air Force has already become paperless, truly. But the real, so the admission process, the medical store, many of these things are becoming more and more paperless. The real problem which comes where the gold mine is when the doctor enters the data in the, now the problem is until you give an extra manpower, which is where it's a little friction point, because it's at some level, it's quite easy to say, it just takes 2 to 3 extra minutes to do the typing. Now, I'm one of the people who likes to do these things, but even there, the moment you've got an OPD of 40, 3 minutes is about 2 to 2 hours extra. The last patient is not excited about going back at 4:30 p.m. just because the doctor is busy typing. So now the point is that this is where there are a lot of friction points, which is there. It's not so easy. Nobody's going to give you manpower. And this is where I think these conversational AIs would actually, this is where we are exploring, because there's nobody going to give you more time. Nobody's going to give you more money. Nobody's going to give you more manpower. But see the power of conversational AI, and I just keep chatting and already 80% is typed. Now I just have to add a little bit more. So these are the directions to explore. So the fundamental thought process is the problems which got created by the third revolution with the coming in of electronics and computer, the pathway is only forward, and we can solve it in innovative ways using the fourth revolution. As far as the huge database which is there with us, I think the step one is we have already started looking at certain specific data points which we are trying to exploit by digitization of data. But I think the big data and the combining everything is still something away. As far as collaboration is concerned, I think we already made some great strides. We have already now, I think AFMC has been fully empowered to get into MOUs with lots of government institutes, and like most of our AI projects, the funding has come from various agencies and it is being done by the team at ISA. So who are asked to the Institute of Science and Education Research at Pune. So we already have got certain projects going on with CDAC in the DERMAT. We have got with ISER in ENT and some other departments. So I think the things are moving forward. But yes, what you're saying is right. They can move a little faster.
Sir, if I may add on to this, what Shankar has said. In fact, Navy is already, made some steps in this direction. we have the Naval Healthcare Information Management System, and we are in the process with our Directorate of Information Technology to, in fact, make our annual medicals and periodic medicals in electronic format. And we also have a telemedicine project which is going on, and it's in the process of the installation of equipments. So the thing is now, of course, what Shankar said is that, to get a data operator or a medical transcriptionist who can, kind of think this is a battle which we've been fighting with our IFAs, and they don't budge, because unless you have government sanctions, this thing. But yes, since it's been a bit of a struggle even in the NHIMS, that's our Naval Healthcare Information Management System. It's been a kind of a huge effort to get people in the OPD to actually, kind of type in, because while you may have a robust software, the hardware also has to, keep pace with the current software. And most of the time, what happens is, again, because of the bureaucracy of procurement of hardware, the hardware lags behind the software. So unless both are kind of in sync with each other and equally quick, using the best kind of speed and all that, only then. But yes, we should be in a position a little down the line to be able to take out data. And as what Shankar has mentioned, we are possibly the largest medical data producers. But yes, it is all lying disorganized, some in paper and some in soft format. The soft format also should have some kind of standardization and some kind of formats. Otherwise, if they are without a proper format, again, it becomes very difficult to call out what information you're actually looking out for. But yes, we as an organization, we have a huge amount of data. In fact, an unimaginable quantum of data which can be kind of analyzed, and a lot of research papers and a lot of good inferences can be drawn out, and a lot of preventive methods, a lot of prevent and control. A lot of things are really possible. So I just hope that all of us, I think one way forward is that the FMS should come together and first integrate all our hospitals, including our field units and all that, so that this data collects, and then of course have the correct formats to be able to put what we really are looking out for.
Thank you so much, Admiral Naveen. I think you've all put it very clearly and succinctly, and we're all definitely proud to be or to have been in the best organized medical service of the country, and we've got huge potential. What I'm saying is the potential needs to be exploited a little faster as well. In my short stint in the corporate sector, and like Shankar was saying that you need a data entry operator for typing in notes. I don't think so. Like I have been using, I've seen around 25,000 patients in the last 3 years, and every single one of them, the notes have been written by me. And you can, make minor modifications to make sure that it will interfere in your conversation. That's a very important aspect, which is correctly brought out. It should not interfere in your the patient's experience with you. But it can be done, and as I said, the willingness and is there, but we can take it to the next level. I only hope that all of us come together, because there is no other set of more well-meaning people than us. And if we can take it forward in the FMS, I think it will be a huge thing.
So there are 3-4 questions in the chat box. Can you see them, sir?
A lot of interesting questions coming up. I think it says, sir, present IT induction is equally hampered by changing hardware standards with actual cost lies. Any solutions moving to cloud storage and virtual consultations? Maybe the DGMS Navy can take this question.
Sir, could you just repeat the question?
Yeah, I'll do that. It says, sir, present IT induction is equally hampered by changing hardware standards where the actual cost lies. Any solutions moving to cloud storage and virtual consultations?
Yes, I mean, virtual consultation, of course, now in the recent COVID-19 has taught us that virtual consultation is important. It brings an air gap between the patient and the doctor, and it saves a lot of time, energy, this thing. So yes, we need to, have IT induction, and it is, to put the hardware changes, and have the data on cloud. Of course, as far as our particular organization is concerned, we are a little reluctant to put too much on the cloud. But in fact, just yesterday at a conference, I suggested that keeping the necessary checks and balances, we could keep our data with with appropriate passwords and systems in check, and permit a kind of a virtual consultations.
Admiral Naveen, the question that I was talking about is, all these things actually we are not our core competence areas. No, you'll agree that
Yes.
What about cyber security? What about privacy laws? What about legal issues arising from all this? So, what is your opinion about the collaboration part? Okay, we cannot actually take it forward to the next level by in-house expertise. What is your view on it?
Yes, sir. So we need to, our armed forces have enough IT experts who are currently, doing a whole lot of things. We could kind of rope them into, guiding the industry, and, accordingly, whatever modifications are required, they can be appropriately put in place. Of course, it is beyond our kind of expertise to be able to guide them. It is they who have to guide us.
Yeah. And the next question is the armed forces gearing up to including artificial intelligence actively in their medical services, and will the patients adapt to it?
Sir, we have, as I mentioned a little short while ago, in the Navy, we've got, our NHIMS, that's the information management systems. We are getting on to an electronic formats of AME, PME, which subsequently we intend extrapolating to our medical boards also. And we have the telemedicine, which is coming in, and putting all these three. These are just the initial steps. Of course, as far as this is concerned, all the three services need to come on the same page, because everything is linked. Our patients are kind of common, our training systems are common, and our hospitals are all integrated. So we need to put all this together. Again, because of budgetary issues, each service has to make their own thing. But I think centrally, the office of the DGAFMS should integrate at least where all the hospitals are on the same page, and we can extract the relevant information.
Thank you,
So
Naveen.
I just wanted to add a small thing to that one, sir. I think patient will have no objection. Most patients see artificial intelligence doesn't have something which stands out separately. The thing is that, like I said, most patients use so many apps. Half the apps have got AI embedded in it, half of them don't have AI embedded in it. So many people, like I gave an example, when you travel in aircraft, the fact of landing and going to the base, AI. So the thing is, it is the contrary to the way the question has been framed. It is not that there is something you do, इस कमरे में AI है, यहाँ पे non-AI वाला, ऐसा नहीं होता. AI has seamlessly integrated into your computer and electronic applications, and the thing is, it just works on making it better. So already there is already an hemophilia app which was developed by Colonel Uday at RR Hospital, and the thing is, it is already being used by hundreds of hemophiliacs, and the algorithm of their blood transfusion runs on AI. So an app can have 5 or 6 functions, and one of the algorithms can be AI based, others can be non-AI based. So I think these are all already part of, patients are already using it, sir.
Yeah, that's very true, Shankar. And before I hand over to the organizers, your final thoughts on the subject, and thereafter I'll move to Admiral Naveen Chawla.
There is one question for Air Commodore Shankar from Rajiv Patni.
So,
Says we have many pilot projects, but they struggle during scale up. Would you like to comment on how to scale up and make the project sustainable?
Yes, sir. So the thing is that the pilot project, he possibly is referring to certain research projects. I may not totally agree with what he says, because we have got lot, though I agree that there are many research projects which are pilot, but on the other hand, possibly the biggest study, for example, we did the win-win cohort, which is 1.59 million people, the largest in the world. You can't scale it up further. That is the ultimate. So the point is that the armed forces has got a huge range of research projects from 30 patients to 1.6 million patients. That is number one. Number two, when it comes to this AI-based project, there is nothing pilot about it. We are actually creating services or solutions. Like, I hope by this next year, when we'll end up having this HIV, the app which is ready, that's a final. There is no, the scale up which would occur is possibly if there are 150 questions which are there in 25 languages. Maybe the people in Africa, they have the same questions. We can convert it to Swahili. Maybe the Russians are interested. The app can go to Russia and Russian. So the thing is that kind of a scale up can occur. So yes, but what he's implying possibly that a vast majority just remain as a small one and they do not scale up. I think that is left individual to individual, sir.
Any final thoughts, Shankar?
Sir, I think AI and IoT are here to stay. This is number one. Number two, I think it's important for all the doctors to kind of understand the magnitude. I just like when I'm preparing for the talk, I was surprised actually that there are more things connected to internet than the mobile phones and laptop. When I looked at the data, it blew me away. So now the thing is that when it is only becoming more and more and more, we cannot get away from it. And I look at it as an amazing tool which has been given, and which the problems which earlier we thought were intractable to solve now can come up with a totally out of the box thinking this thing. So if you just land up thinking it of as a bacche ke haath mein ek chota sa tool de diya and you can play around with it, I think we should all start playing with AI, and we would be able to come up with some really amazing solutions. The problems only you can determine, the doctors who are actually facing it day to day. I cannot find out what is your problem in your this thing. But once you have got a problem, talk with 4 or 5 other people who are generally very excited with life. You've got people in IITs, ICERs. You can talk to me, you can talk to anybody, and solutions will easily come out. Then work on a solution, and that's your product, sir.
Thank you so much, Shankar. And Admiral Naveen Chawla, your final thoughts, please.
Yes, sir. I fully endorse what Shankar has said. There is no stopping AI. Sir, it is, in fact, already a way of life, which is only going to get bigger and bigger with time. In fact, as I had mentioned in my talk, I really like this motto of this National Digital Health Mission. And that's my summary. And I quote this: think big, start small. So we are already at that stage, but we have to scale fast. So we need to kind of come together, and whatever small efforts which we are doing, as I mentioned, in the Navy, some efforts are already on. I think we need to scale up fast, for which, all of us in the armed forces, as I said, resources are there, resources are to be found. So while there is a, economy of cost, the ethics, legality, of course, the government has to put in place. I think armed forces can definitely play a big role and, take the burden of costing forward. And so again, think big, start small, where we are, scale fast. So scale fast is what we need to look at. We have to be all open to ideas and come out of our current comfort zones and, take our hospitals and our healthcare units, our MI rooms, take them all forward. And as long as, I don't think as far as health is concerned, it's something we can't have on the internet. Yes, with checks and balances, we can put an amount of data there.
Thank you ever so much, Admiral Naveen Chawla and Air Commodore Shankar. That is a lovely time that I had chairing the session. You all spoke so well and discussed some of the most important aspects of the subject threadbare. Thank you once again. And I'll now hand over to General Ravi Arora to take the proceedings forward.
Over to General Srivastav, sir.
Thank you so much, General Narayanan, Admiral Chawla, and Commodore Shankar. I think we've indeed had a very informative and a very interesting session. We walked through the policy issues and the challenges that were so well flagged by Admiral Chawla, and the use cases that Commodore Shankar so lucidly explained. I think if we understand the manner in which he has identified situations where artificial intelligence can help out, I think the services too need to look deeply in each business process that they have. And I'm sure with that kind of manner in which he has identified, I think there could be pointers, like somebody mentioned, a searchlight being shown. So very interesting indeed. I'll just close with one observation and one lighter one. So first the serious one. One is that this cohort of ex-servicemen, it lends itself ideally to apply all these techniques for a couple of reasons. One is that they are located in areas where connectivity mostly is not an issue. Yes, there would be places in remote, but largely they're spread as in metros and small towns. So that's where I think it can cut costs seriously if we look into meaningfully using artificial intelligence for healthcare and monitoring of ex-servicemen. And it can lead to lessons for the other cohorts. And the second thing is that I think we are a little hypocritical when it comes to health, our data, privacy, medical data. Children, wives, all the time are gifting Fitbits and such like gadgets to us, and we wear them every day. We want to count our 10,000 steps, and our data, whatever we value, is already out there. So I think the larger issue is keeping healthy. The challenges to security can be found. We are so glad that our systems are beautiful. We are not having instances like the Western Theater commander of China. One of them, not even 60, just died, and the other one had to be removed for health reasons. And they claim to be a kind of a modern and a progressing army. So I think we are much more honest about things, and we are progressing things in the right direction. I think we're really thankful to all of you for having had such meaningful session, a very meaningful session.
Thank you.
So much.
Thank you, sir.